from Canada, so that's great.
We have about 25 folks on right now, and I have the top of the hour, so why don't we go ahead and get started here. I'd like to welcome everyone to the SADS Foundation's third webinar in our Living with SADS series tonight on Brugada Syndrome. I'm Marcia Baker. I'm the Program Director for the SADS Foundation. So before we begin the webinar, I have a couple reminders. First, please keep your audio muted during the PowerPoint presentation to improve the sound quality for all. Second, following the presentation, we have allotted plenty of time for Q&A with Dr. Lubitz. To ask a question verbally, you can just unmute yourself or type your question into the chat anytime during the presentation. And we'll address some of those questions during the presentation and others at the end. Today's webinar is being recorded and may be accessed later on the SADS YouTube channel. And we'll send the link to you following the post. So now I'd like to introduce our speaker, Dr. Stephen Lubitz. Dr. Lubitz graduated from the University of Michigan Medical Center. He trained in internal medicine and cardiovascular disease at Mount Sinai Hospital in New York, where he also served as the chief medical resident. Dr. Lubitz earned a Master of Public Health degree from Harvard University School of Public Health. He completed his clinical electrophysiology training at Mass General Hospital in Boston. Stephen is an adult electrophysiologist at Mass General Hospital. His clinical interests focus on the diagnosis and treatment of patients with cardiac arrhythmias, including Brugada Syndrome, long QT syndromes, plus many others. It's my pleasure to welcome Dr. Stephen Lubitz and hear his presentation tonight on Brugada Syndrome. Steve?
Thanks very much. I'm honored to be here tonight to speak with everybody, and I appreciate the SADS Foundation extending this offer and invitation to speak to you tonight. I understand that we have a mixed audience as well of healthcare providers as well as patients and family members. So hopefully I'll be able to cover a lot of territory tonight, and hopefully I won't be too technical at times. If there are any questions, feel free to go ahead and just share them in the chat. I'll be trying to keep an eye on that, and we can make this as interactive as people would like to make it. So don't be bashful. As stated, I'm an electrophysiologist at Massachusetts General Hospital, and I help direct our cardiovascular genetics program. I focus on arrhythmia genetics, and I think we'll get started now. So by way of high-level overview and introduction, Brugada syndrome is marked by this classic ECG pattern. And you can see here these leads that we call, when you get an EKG, there are 12 leads. So we tend to refer to the EKG as a 12-lead EKG. And each of those leads, each of those 12 leads refers specifically to a certain orientation of electricity in the heart. Leads V1 and V2 are basically right in front of the chest, and that is overlying a structure called the right ventricle, one of the pumping chambers of the main pumping chambers of the heart on the right side. And there's this ECG pattern, this classic ECG pattern marked by this up and down stroke, but then this curved stroke. I don't know if you can see my cursor, but then this curved stroke just after this complex here that a cardiologist will see and say, aha, that looks like a Brugada pattern. So this is sort of a telltale pattern on the EKG. It can be caused by a few other things, but typically we think of Brugada syndrome when we see it. And that can happen either spontaneously, or that can happen in people who have a susceptibility to this condition when it's induced either by medications or a fever. Those are some of the more common precipitants of this pattern in people who have a susceptibility. It's a pretty rare.
We can't see your cursor. It's good.
You can. Okay, great.
Yes.
It's it's a pretty rare condition. You can see the prevalence here. It tends to affect people during young to middle-aged years of their lives. It tends to affect men much more commonly than women, roughly an 8-to-1 ratio. The clinical manifestations that we think about, often it's an asymptomatic condition, and the EKG can be, this pattern can be noted incidentally. the ECG abnormalities can come and go, so we can see that pattern. Sometimes it's always there, and in other people it'll be present, and then on another EKG it'll be absent. But what we really worry about are these ventricular arrhythmias that can lead to low blood flow to the brain and other parts of the body, and ultimately can cause people to faint or even die suddenly. The predominant gene that's responsible is a gene called SCN5A. This is a workhorse gene in the heart that's involved in the development of the heart. It's involved in electrical communication in the heart. It's involved in the formation of the structures of the heart. And at the same time, most people, when we do sequencing and we look at SCN5A or we look at some other genes, we can't find a smoking gun. We can't find the genetic variant responsible for the condition. We call them genotype negative. So that's one of the unmet needs that I'll actually close the talk with today. The condition has an interesting history in that in the 50s, the pattern was actually recognized on the ECG and was considered a normal variant because the incidence of adverse events is so low in Brugada syndrome that this was generally regarded as a benign condition. I see a couple of red marks on the screen. I don't know if they're bothering people. I don't know how they got there, and I certainly don't know how to erase them. So I'm just going to ignore them and pretend they're not here and hope they don't bother anybody. In roughly the 90s, late 80s, 90s, a few reports started to emerge about this particular pattern being related to ventricular arrhythmias. And in particular, there was a report by the Brugada brothers that summarized this in the Journal of the American College of Cardiology, in which they summarized a series of patients who had this abnormal ECG pattern and who had sudden cardiac death. And henceforth, the condition was coined the Brugada syndrome. And for folks that are familiar with some of these other conditions that we tend to talk about when we think about sudden cardiac death, long QT1, long QT2, long QT3, overlap syndromes, catecholaminergic polymorphic VT, which we call CPVT, Brugada syndrome, which I'm labeling as BRS. You can see here on the x-axis is just the age of individuals in a series. And I won't get into the details of this particular analysis, which is a very nice research paper. And on the y-axis going up here is the standardized mortality rate. You can see that Brugada syndrome in this orange color tends to have its most prominent effect in adulthood, in the 40s to 60s roughly. So reports will span anywhere from sort of the 30s to the 60s. That's not to say children can't have it or have manifestations of it, but it tends to be more rare at younger ages. And that may have something to do with hormones. It's not entirely understood why that's the case, but this is when we tend to see Brugada syndrome most often present. So a quick summary on what we think might be going on with Brugada syndrome. And I'll just orient you over here on the right-hand side of the screen. This is the right lung. You can imagine that this person is facing you. So this is the right lung, this is the left lung, here's the heart, and this is the right ventricle. This here is supposed to be a cardiac cell. Here's the nucleus of the cell where the DNA lives. And then here's a channel that lets electricity in, and here's a channel that lets electricity out. Here's what we call the cardiac action potential. On the EKG, this is represented by the lumps and bumps that we see, including that QRS complex and ST segment that we tend to focus so much on. And if this is a normal current or normal balance of current in the heart, in Brugada syndrome, what we think is happening is that in this region overlying the right ventricle, there tends to be a reduction in inward current and potentially an increase in the outward current that leads to an imbalance essentially in the electricity across the heart. And we notice that on the EKG as this EKG pattern. And because of the way the electricity works, it sets up a situation where some parts of the heart are more susceptible to arrhythmia than other parts of the heart when that pattern is present, we think. And in particular, the reduction of that current coming into the cell is a reduction of sodium current, which is a molecule that carries an electrical charge. So it's one of several electrolytes in our bodies that carry electricity across cells. So I'm going to transition now and talk a little bit about genetics. And to do that, just for folks who don't think about this every day, I want to give you a background on some of the basic vocabulary that I'll refer to. There's no quiz at the end of this, but if you do have questions, feel free to interrupt. So DNA is a chemical structure comprising 4 nucleotide bases. We refer to them as letters A, T, C, and G, and they're arranged in 2 paired strands. The genome has about 3 billion base pairs of these. Organized onto chromosomes, we have 23 pairs of chromosomes. And genes are units of the DNA that actually form a protein. There are about 20,000 genes in the genome. The exons are the parts that make the protein, and the introns are they're parts of the gene that are in between the exons. We refer to things as polymorphisms when they're common, these changes in the letters up here, A, T, C, and G. And we refer, I don't have it on here, but you'll hear the word mutation oftentimes. That just means a very rare change in A, T, C, and G. And the more rare something is, often the more likely it is to have an effect that we see in some manifestation in the human body. And that's not always the case, but that tends to be often a principle that we follow. I won't bother with the rest of this. And just in a cartoon fashion, if we start here, you may remember that there are a lot of cells in the body. Inside of the cells is the DNA in the nucleus, 23 pairs of chromosomes. If we unravel the chromosome, it's this double-stranded DNA. And then regions of the DNA form genes. And then you see here this double-stranded DNA has these nucleotide base pairs that I was talking about 3 billion in the genome. And a process, just so you understand how we get from genes to our bodies. So you start with the chromosome unwinds a little bit, the DNA strand opens up a little bit, and then some enzymes come in and they transcribe the DNA into an intermediate molecule called RNA. And then that RNA leaves the nucleus of the cell. That's this dark shaded part. The RNA leaves and it travels to the rest of the cell, which we call the cytoplasm, where there's a machinery that reads the RNA and starts to assemble proteins together. It takes amino acids and creates this chain of a protein. And then the protein goes and does its job. So this process is called transcription before you get to RNA, or the process of making the RNA, and then RNA to protein is called translation. And when we think about genetics, we tend to think of very rare, in clinical practice, we tend to think of very rare genetic variation when we perform genetic tests. So if you're a patient, perhaps you've had a genetic test done, and this is sort of the way your doctor's thinking about it. The genome is this big circle here, and the exome, or those 20,000 genes, comprise roughly only 1% of the entire genome. So there's a lot of other stuff here that plays a role in the way that the proteins get made, that transcription and translation happens, but it doesn't directly make protein. So there's only about 1% of your genome that makes protein. And then among that exome, that portion of the genome that makes protein, only a tiny sliver of it is what we think about in cardiology. So if you had a genetic test, it's likely that your doctor did a very focused test looking at a very tiny slice of your genome to try to find a genetic variant that might be responsible for a condition that you have. And in this case, we're talking about Brugada syndrome. And the reason we don't usually look at everything is because there's so much there. There's a lot of variation between each of us, and it's very difficult to try to make sense of any of that. We're getting better at it, but we're still a ways away from being able to read an entire genome and say, aha, I understand everything that's going on in the genome here and how it relates to the way this person is made. And we talked a little bit about the biology of Brugada syndrome. There are a lot of important cardiac channels in the heart that underlie inherited cardiac arrhythmia syndromes that may lead to dangerous arrhythmias and sudden cardiac death. But in particular, we're focusing again on this channel here, which carries sodium. We shorthand notation for sodium is Na, and this I in front of it means that this is a sodium channel current. And remember, we were talking about sodium coming into the cell. In Brugada syndrome, there tends to be a net reduction in that inward sodium current coming into the cell. this current, this channel, a major part of this channel is made from this gene product from a gene called SCN5A. There are a few other parts to this channel, but SCN5A is really the workhorse of this sodium channel. And so when we—
Could I ask you a question?
Please.
I hear a lot about SCN5, the one you're talking about. My husband collapsed at 42 with GPD1L, and now my 13-year-old son has it as well. What's the difference?
So I didn't hear all of what you said. I heard that your husband collapsed, and
Yes, when he was 42,
and there was a
10 years
genetic
ago.
change in— Sorry, can you say that again?
My husband collapsed when he was 42, 10 years ago.
Mhm.
And I have a 13-year-old son now that has the same genetic mutation. It's the GPD1L. And I was just wondering what the
Okay.
difference is, because he has cousins in his family that have the SCN5 gene.
Yeah. So this gets a little confusing, and in Brugada syndrome in particular, this is especially confusing. So there have been a number of genes that have been suggested to be related to Brugada syndrome, and it's likely that there is more than one gene that's causal for Brugada syndrome. The one that has the most robust evidence behind it is SCN5A. And there are a number of other genes, and you just mentioned one, that have been implicated in Brugada syndrome where there's pretty good evidence. Without knowing the details of all the genetics in your family, it's hard to comment, because even when we look for genetic variants, there's even more ambiguity when we try to score the genetic variant that we find in a gene, and we say, how likely is it really to be related to a condition? Is it very likely, or is it not very likely? And there's a gradient there. When we look at a variant, we don't necessarily know that it clearly is. In some cases it's obvious, in other cases it's less obvious. So it sounds like there might be some question about what the causal gene is or causal variant is in your family. I'm not sure. But without getting into too much detail, I'll just say that the one gene that has the most evidence behind it in Brugada syndrome is SCN5A. That doesn't mean that other genes are not involved in it.
Okay. Thank you.
Sure. And as I alluded to at the beginning of the talk, one of the problems and unmet needs in Brugada syndrome has to do with your specific question. And that is that when we go looking for genetic variants underlying the condition, in Brugada syndrome, only about 20–30% of the time do we find a genetic variant that we think is really responsible for the condition. And just by way of comparison, if you look at long QT syndrome, another condition we take care of, about 80% of the time we can find a gene variant responsible for the condition, and somebody who we're really confident has the condition. And so you see this gradient here across the conditions that we think about in this
So my question, I
area.
guess, to you is, if I could, I'm trying to keep my son alive. And
Yeah.
is there any more? Is one gene mutation any worse than another? More, you know what I mean? More likely to cause death, or you know what I'm saying?
Yeah.
I don't know how to ask you these questions because I don't understand it.
Sure. Yeah, let me try to answer this way, and I don't know if it'll be an incredibly satisfying answer to you. What we know about the genetics is that they're related to the presence or absence of the condition, but we don't have a lot of evidence or very strong evidence to tell us that a particular genetic variant is more likely to cause a dangerous arrhythmia or not. There's some data, but it's when we look at an individual patient in the clinic and we talk to them, we don't usually factor that type of information into our risk stratification approach. Usually when we think about how likely somebody is, and I'll talk a little bit about that actually in this talk, when we're thinking about how high of a risk somebody is at for having a dangerous arrhythmia, whether we should talk about a defibrillator or not, we're really thinking about clinical factors. It has a lot less to do with genetics in most circumstances. And that's especially the case in Brugada syndrome.
Okay. Thank you.
Sure. So, and again, along these lines, one of the reasons, one of the challenges in Brugada syndrome is that we don't always find the genetic variant underlying the condition. And so that leads to the importance of family screening. And family screening doesn't necessarily mean genetics. If somebody in a family has a negative genetic test, then it doesn't make a whole lot of, and they're affected, it doesn't make a whole lot of sense to do a genetic test in somebody else in the family. It does make a lot of sense to do a clinical test. That could be an EKG, that could be another type of test that we think about. And these tests might need to be repeated over time. And the advantage of doing that is that we can keep an eye on people in the family to see if they develop the condition or not. This can involve a combination of clinical tests, as I mentioned, an EKG or a drug challenge, in particular procainamide in the United States, or perhaps flecainide. In other parts of the world, they might use a drug called adjmoline. But the utility of that particular test is sort of questionable, and we'll talk a little bit about why that is in a bit. And then genetic evaluations. If a relative with a Brugada pattern or ECG on their ECG has a clear-cut genetic variant that we think is responsible for the EKG pattern, then it makes perfect sense to go ahead and test other people in the family if they're interested, to see whether they carry that genetic variant or not, because it'll tell us whether they're at risk for developing the Brugada syndrome or Brugada pattern on the EKG, regardless of whether they have it at that moment or not. And this is I wanted to just sort of transition to allow me to talk a little bit about some of the research that's happening right now before we move back to the clinical aspects of the condition. So when we think of genetic variants, they're not all the same. So some are very common and they just make us different from one another. Others are exceptionally rare and they might be private to you or to your family, and they might not have been seen before. Those rare ones tend to have very large effects. And these are the things that we see in families. We call them monogenic variants or mutations, or they might be represent a Mendelian condition. And in the case of Brugada syndrome, oftentimes there's just one copy of that genetic variant transmitted from mom or dad through the family. And that means that each child has about a 50% chance of inheriting that genetic variant. The common variants are very common, and we can study these common variants because they're so common using large studies where we gather volunteers who want to participate and contribute their DNA. We can do the same thing with these rare ones, but we need really large samples or families with many affected individuals to be able to identify these rare genetic variants. I'll talk a little bit about that. There's a question that I saw come up. Does the lead placement play a factor in looking for Brugada pattern in EKG? That's a great question. So in the clinic, and it does. And so in the clinic, those leads V1 and V2, which are basically right in the fourth intercostal space here between the ribs, we will often move them up one space and then up another space in the clinic to see if we can elicit the Brugada pattern. It turns out that because of the way our hearts are oriented, in some people, moving those EKG leads up, V1 and V2, can help bring out that Brugada pattern. So we'll often do that in the clinic. So now I'm going to transition away from these mutations to these polymorphisms, these more common variants, and tell you just about something you may have read about in the news or heard about. This is called a genome-wide association study. These are incredibly common. And in the last 10, 15 years, there's been a revolution in human biology, just in terms of understanding how we're made and what regions of the genome and pathways biologically underlie why we look the way we do, why we behave the way we do, and why we get the diseases that we get. And basically, you can think of this very simply as an experiment where you take people with a disease and then people without a disease. These you isolate DNA from these folks, and then you run them over these little chips that have these chemicals on them that bind the DNA in certain regions. And then you count up at each of those positions, and that chip might have a couple 100,000, it might have 1 million of those chemical structures on it, looking at a polymorphism that we know exists in the genome. And then basically you just compare at each of those you know, 100,000 to millions of positions that you end up studying, whether the variants are more common in the people with disease than in people without the disease. And so here's an example where it's about the same. Here's an example, these green dots here are about the same. And then here's an example where SNP3, single nucleotide polymorphism 3, is more common among people with the disease than it is among people without the disease. They've colored it red here in this cartoon. And so here we would see, statistically, we would see a blip on the radar screen that says, aha, right where SNP3 is, and we know where it is because of genetic mapping, there's something going on here related to Brugada syndrome. And then that points us to the disease susceptibility genes. And we'll show you what that looks like. And then you can also start to add up the genetic variants that somebody carries and say, well, what's their genetic predisposition? What's the burden of genetic risk that they have for a given condition? And we call this a polygenic risk score. So if you imagine you have a person here, they have a disease susceptibility variant here, here, we give them a score of 3. This person get a score of 2. This person down here would get a score of 4 because they have 1, 2, 3, 4. And then ultimately you have a distribution in the population, and you see that some people are at high risk, some people are at low risk. And then you can use that as an instrument to try to figure out whether somebody is more or less likely to develop Brugada syndrome. And I'll show you this in action. So here's a genome-wide association study published in 2013 for Brugada syndrome, in which there were 312 individuals with Brugada syndrome and 1,000 people without Brugada syndrome, roughly. These are the 23 chromosomes in the body. As you can see here, each one's color coded. On this axis here is just the strength of association for each of roughly 10, I think in this experiment, they may have had 10 million variants that they tested for association. And we like to see these blips on the radar that I was talking about. We call this a Manhattan plot because we like these skyscrapers. We like to see these tall peaks. And we know what lives right here in this part of the genome. We know what lives right here in this part of the genome. So if we zoom in, we start to see there's a signal of association here. Sure enough, right upstream of this gene SCN5A. Well, that makes sense given what we know. But there's also a signal at this gene here, HEY2. And so there, we can do this, and the experiments are getting larger and larger now, where we can do this in much larger samples, and then we start to see more skyscrapers. And this is really going to be the key to unlocking the causes of Brugada syndrome and other conditions. Then we can add up the significant signals that we identify in this experiment. You don't have to worry about this here, but basically we can create what I told you about on the last screen, polygenic risk scores, and we can just see how if you have more of these risk variants, your risk of getting disease goes up here. And so that's an important tool that we might start to use in the clinic one day. We're not quite there yet. We're just starting to think about how we might implement that in the clinic. But hopefully that walked you through how we think about using genetics. I'm going to transition now to risk stratification, but I see a question first. So let me just read that. This is a terrific question. So this has to do with disparities in healthcare. And it's no secret that there's a huge underrepresentation in genetic research of non-European ancestry individuals. There are dedicated efforts underway to try to recruit non-European ancestry individuals into research studies. Actually, there's a really big study in the United States called All of Us, in which that is a primary goal, is to increase the diversity of a very large prospective biobank, essentially, and have people contribute their medical information, including their DNA. And this is a big problem. And the disparities in healthcare also reflect access to research opportunities as well. So we know less than we should know about individuals with non-European ancestry right now. And the genetics, because of migration patterns and things over time, the genetics do differ from one ancestral group to another. So we can't apply learnings from European ancestry individuals to necessarily African individuals of African descent without some caveats. Does that risk correlate to degree of risk in being symptomatic? We don't know that actually. It's a good question. And we don't know that. The risk that I showed on the prior screen really was focused on the presence or absence of the condition, but I know there's some follow-up work ongoing to try to determine whether these scores are also related to the risk of developing an arrhythmia and having symptoms. So good question. And the answer is basically we don't know that yet, but that's where things are going. So I'm going to transition and talk a little bit about the clinical risk stratification and management. And as I mentioned earlier, the genetics don't play that big of a role at the moment. And what we do think about, though, are basically two categories of clinical features. So one is, have you had a symptom from Brugada syndrome or not? Yes or no, and if so, what kind? And then two is, do you have an abnormal EKG? Or I'm sorry, if you have an abnormal EKG, how did you get that abnormal EKG? So if you've had a cardiac arrest or a ventricular arrhythmia, which I've abbreviated VA, you are at very high risk. That's denoted by this dark red or purple here. And the highest risk category would be somebody who has that abnormal Brugada pattern on their ECG spontaneously. You tend to have a slightly lower risk if you have a drug-induced ECG pattern that's abnormal and induces that Brugada syndrome. If you've had a fainting episode, now a lot of people have had fainting episodes, but it's important here to recognize that people who've had arrhythmia-related fainting episodes are at high risk. And sometimes that clue comes out when your doctor asks, how did you faint? What were you doing right before? What were you doing right after? How did you feel? Did you hurt yourself? And so there are clues in the history that will let the doctor zero in on a degree of suspicion that helps them understand whether it was likely to be arrhythmia related or maybe the common cause of fainting. You saw blood or you were frightened or something else happened that made it less concerning to them. People who've had arrhythmogenic syncope are reasonably high risk if they have a spontaneous ECG pattern, slightly lower if they have a drug-induced pattern. And if somebody's asymptomatic and they have a spontaneous ECG pattern, they do have a degree of risk of ventricular arrhythmia, but it's not incredibly high. And so this is probably the one category of individual where doctors will scratch their heads a little bit and say, okay, we really need to have a conversation about how we want to move forward with this. And I'll tell you what the community has sort of settled on at the moment. But this is the area that presents a bit of a clinical conundrum. Individuals who are asymptomatic and maybe they have an induced pattern, they don't have it at rest spontaneously, are at very low risk. And I'll give you some numbers here. So we did a study in which we asked some of our colleagues in the field to help contribute data to a pooled analysis. This was published in 2016 in a journal called Circulation that cardiologists read, in which there were 1,312 individuals with Brugada syndrome without a cardiac arrest who had undergone what is called an electrophysiology study. And we basically asked all of our collaborators to send in their individual level data that was anonymized. And among 1,300 patients, there were 65 people who had a ventricular arrhythmia during some period of follow-up. And we said, okay, what are the predictors of adverse events? And is this study called an electrophysiology study where we put catheters into the heart any good at helping us discriminate risk? Because that's existed as a controversial figure or option in Brugada syndrome for a long time. So here's that same table I showed you. And if we turn the event rates into annual percentages, and you may ask, what's my risk annually of getting a ventricular arrhythmia if I fall into one of these buckets? Well, we didn't analyze people who had a cardiac arrest or ventricular arrhythmia because we know their risk is very, very high to begin with of having another event. But if you've had arrhythmogenic syncope, what we saw was the rate was about 3.2% per year among those with a spontaneous EKG pattern, 1.4% if they had a drug-induced ECG pattern and had arrhythmogenic syncope. These would be considered considerable numbers in the clinical community. If they were asymptomatic and they had a spontaneous EKG pattern, the rate was about 1% per year, and it was very low with a drug-induced pattern if they had no symptoms, so 0.3% per year. My guess is that all of these numbers are slightly inflated because the people who participated in these studies were people who underwent this invasive procedure, an electrophysiology study. So there may be some referral bias that drives up the numbers in these particular patients. So I don't know that for sure, but my guess is that the real numbers are probably a little bit lower than this. And we see in people who have defibrillators that, you know, for the sake of time, actually, I'm going to skip this slide. And I'm going to just talk about the electrophysiology study piece here for a moment. And I just want to show you that this question about whether an electrophysiology study, which is this procedure where we put catheters into the heart and we stimulate the heart and see if we can induce a dangerous arrhythmia, and say how likely is it that we can induce that arrhythmia or not, which in some forms of arrhythmia or heart conditions can be very informative. This question has come up over the years, and you can see the Brugada brothers here arguing that it's an important thing to do to stratify risk in patients with Brugada syndrome. And you can see here a countervailing argument that perhaps it's not a very helpful test. So you can see these, and these are all reasonable people in the community. These are all experts, knowledgeable people disagreeing about the utility. And so in that study that I was just telling you about, you know, we asked the question and we said, okay, what happens if you have a positive electrophysiology study where we are successfully induce the arrhythmia? What happens if you have a negative electrophysiology study? And so right now I'm just showing you the annual rates of events in those categories. So if you fainted and you had that spontaneously abnormal EKG all the way down to asymptomatic drug-induced ECG. And then if we ask what happens if you factor in the EP study, that electrophysiology study, you see there is an association. So the risk of events is much higher if you have a positive EP study. The problem is that if you have a negative EP study, it doesn't take away your risk. There's still people with a residual risk of events moving forward. So in the field, this test is considered an ancillary test, and some doctors will recommend it very strongly. Other doctors will say, well, I'm not sure how to use it or if it's really going to help us here, because if it's negative, it doesn't, you know, substantially reduce the risk in the category in which we have the most trouble, which is this one here, the asymptomatic with the spontaneously abnormal EKG. But we also know that if you're very aggressive about the EP study, this is a little bit of inside baseball for the electrophysiology community. If you're really aggressive and you try to induce very hard, or if you try to induce arrhythmias in a very aggressive manner, the utility of the test goes down. And so if you're a little less aggressive about using the test or the way you do the test, there's a little bit more predictive utility in terms of just figuring out who's more likely to have an event. And so the treatment really centers on these considerations here for somebody with Brugada syndrome. So the mainstay would be an implantable defibrillator for somebody in the highest risk stratum of Brugada syndrome. And so that might be somebody who's had a cardiac arrest. That might be somebody with arrhythmogenic syncope, or fainting. But people who are asymptomatic, generally, we don't talk about an implantable defibrillator. Generally, we'll think about observing them because the risk is deemed to be sufficiently low. In some cases, we might consider quinidine, which is a medication that can alter the electrical currents in the heart in such a way that it can reduce risk of events. I'm sorry, I hope you don't hear my dog barking in the background. And if it's distracting, I apologize, let me know. And in other cases, one of the more exciting aspects of Brugada syndrome in the recent past, in the last 5 years or so, is that catheter ablation seems to be potentially an effective solution for people who have refractory arrhythmias. So they have ventricular arrhythmias kind of over and over again. Ablation tends to be effective. So it seems like for people who are getting arrhythmias over and over again, maybe they're getting shocks from the defibrillator, quinidine or ablation might be good options. There's some question about whether quinidine could be a good first-line agent, but that hasn't been really robustly or rigorously demonstrated yet. But that might be something we see in the future. And I see a couple of questions. Is risk genetic? I'm asymptomatic and presented spontaneously. Would my daughters also diagnosed be low risk as well? Yeah, good question. So if family history doesn't turn out to be a great predictor in Brugada syndrome, so if you've had, so what I should say is, if somebody's had if there's a relative who's had a cardiac arrest in the family, it doesn't mean that other people in the family who might have it are necessarily at increased risk of having a ventricular arrhythmia either. If they're, and I think the corollary of that is that if somebody's at low risk in the family and they've not had an event, we can't guarantee that somebody else in the family is at low risk too. So we would basically start by asking these other individuals in the family, do you have an abnormal EKG that was spontaneously abnormal? And have you ever had a dangerous arrhythmia or not? Or have you ever fainted before? And if you fainted before, did we think it was related to an arrhythmia or not? So that's how we would sort of think about it on an individual level basis. Is there any further research about other symptom presentations other than syncope or ventricular arrhythmias and their risk factors like palpitations, et cetera? Rarely see them in any risk stratification. That's true. Yeah, I think for Brugada syndrome, what's kind of shaken out over the years is that these are really the key clinical risk factors. There are some other risk factors that some people are starting to get excited about. There might be some abnormalities on the cardiac MRI in the heart that we see, or there might be abnormalities on the EKG that we can interpret that might add some incremental value beyond the clinical risk factors that I mentioned, the EKG spontaneous or induced pattern, or whether they've had an abnormal arrhythmia, had a fainting episode that we think is related to arrhythmia or not. But largely, those are the mainstays right now, and other symptoms like palpitations don't really play a big role. Since the defect is in sodium channels of each cell, what exactly do they ablate? Great question. This is a terrific question. So we don't know, the bottom line is that we don't fully understand Brugada syndrome. We think that what might happen is that, so SCN5A is not just carrying electrical current. It also probably has something to do with the structure of the heart. And in some cases, we think that there might be a structural abnormality that contributes to the EKG pattern and arrhythmia susceptibility in that region of the heart, in that right ventricular outflow tract region that I showed you that map of before. And so if we can get the catheter over to that region, and if we can find areas that look like maybe there's a little scar tissue there, that probably results from this process that we don't fully understand molecularly yet, then we can ablate and minimize the risk of arrhythmia. Okay, and I'm not going to go through this, but these are, just so you know, there are guidelines that we follow in cardiovascular medicine, and there are guidelines specifically for how to manage a patient, how to risk stratify a patient, and how to manage a patient who has Brugada syndrome that we all adhere to. And a few different societies put them together. This is from the American Heart Association, American College of Cardiology, and the Heart Rhythm Society. And in Europe, there are similar societies that do this. They all largely agree with the treatment recommendations. So this is just by way of letting you know that there are actual guidelines that we follow. And in addition to the sort of basic treatments that I was telling you about, we will recommend to everybody to avoid Brugada aggravating drugs. And there's a website, brugadadrugs.org, that has a very nice compendium of medications that can block the sodium channel and exacerbate the EKG pattern and potentially increased risk of arrhythmia. We ask everybody to take Tylenol to treat their fevers because we think fevers can bring about this pattern as well. We ask people to avoid excessive alcohol and other cardiotoxic stimulants like cocaine. And so those are all basic lifestyle changes. And then the rest of it is the medical stuff that I was just telling you about. Okay, so there's another question. My son, now 25, had his first cardiac arrest event when he was 15. He has an ICD, takes quinidine 3 times a day. How safe is cardiac ablation? What are the risks and side effects? Thank you for your question. I'm sorry to hear about your son. It sounds like he's doing well. And I think if he's doing well, that's great. The biggest risks of catheter ablation would be, the catheters typically will go into the groin, into the femoral veins, and then go up into the heart. So sometimes there's a venous access issue where somebody might get a bruise or a vascular complication in the groin. That's pretty rare. And then in the heart, when we ablate, there's always a small risk that we can perforate or poke a hole in the wall of the heart when we're ablating or moving catheters around. There's a risk that we could injure the electrical system of the heart if there's a spot that we want to ablate that lives just beside the nerves of the heart that carry electricity, and then somebody could need a pacemaker. For and then when we're in the heart, we always, worry about a heart attack, a stroke, or something even more dangerous, blood collecting around the heart, or even something fatal happening. Having said that, electrophysiology studies and ablations tend to be pretty safe procedures, particularly for people with Brugada syndrome who don't really have many other cardiovascular comorbidities or problems. They tend to be on the younger side in general. This is usually the only issue that they sort of carry with them medically, and the procedure tends to be reasonably safe. Now, for ablation of Brugada syndrome, oftentimes will be in the outside of the heart, so the access might be just below the sort of sternum here, and we might be ablating sort of on the outside of the heart. And in that case, we have to worry about the coronary arteries that carry blood to the heart too, and just trying to avoid them. But a skilled operator, this is pretty standard stuff for a skilled operator. So that's the kind of thing we can work with. Do you have any recommendations for young children, 2 years old and 5 years old, who have Brugada? They each have an AED, stay hydrated, avoid the drugs, treat fevers aggressively, have action plans, place no CPR, give routine, anything else they can be doing. Father is symptomatic, type 1, with an ICD and had an epicardial ablation, right, in December 2019. The kids each have positive genetic tests, and sometimes it shows on their EKGs. Okay, yeah, so great question. And I'll start by saying I'm an adult electrophysiologist, so I don't take care of pediatric patients with Brugada syndrome, and I would refer to my colleagues. That, I think the general principles of management are similar, and those are basically to support and observe patients who don't have a high-risk feature like a history of a fainting episode that we think might be related to an arrhythmia. And it seems like there's been a pretty comprehensive counseling and treatment strategy in place in your case, and that's great news. So I don't think that there are additional specific recommendations for children of that age, as you mentioned. And I would also add that, whenever we do something, and let's call it a defibrillator, for example, implanting a defibrillator is not a trivial procedure, because the battery only lives a certain amount of time, the leads only live a certain amount of time, people can get shocked inappropriately, and that can decrease quality of life. So we have to be really careful about prescribing therapy indiscriminately in patients with conditions like this. And in particular, things like a defibrillator. And so, it'd be great if at some point we could figure out the causes of Brugada syndrome and identify or develop therapeutics or medications that target the specific mechanisms of Brugada syndrome in everybody, and then prescribe those in a way that can minimize risk. It sounds like they're on quinidine already, which seems to be in a lot of people is reasonably well tolerated, and it seems like can minimize risk, although we need more data. Okay, so I had a few vignettes. I think if we have time, I can go through the vignettes, and I'll look to Alice and Marcia to tell me whether I should just keep going at this point. Okay, unless I hear otherwise, I'll go through it. And I just wanted to take you through sort of the way I would think about these cases, patients that present, to give you a flavor of the kind of medical thinking behind patients with Brugada syndrome. So I'll show you a few vignettes. I think I have 3. So this is a 37-year-old female with an abnormal EKG who had no symptoms. This is the EKG. So remember, we were talking about lead V1 and V2. They're right here. And there's an abnormal EKG. It doesn't quite meet the Brugada syndrome criteria, but I can tell you that that's not a completely normal EKG. Here she is, 37, big family, and she has a son with a ventricular septal defect. There are several cardiac arrests in her family. So I'm sorry, if you haven't looked at these, this is a pedigree. A circle is a female, a square is a male, and each row represents a different generation within the family. So this is her, and she has 3 children, ages 13, 7, and 5. 5-year-old had a ventricular septal defect. This is her father here. He had a cardiac arrest, was resuscitated. He had a sister who died at age 60 of a heart condition. He had a brother who died in his sleep at age 65, another brother who died in his sleep at age 67. So what, I'm thinking, what do I do next? Do I observe Do I treat with quinidine? Do I perform a drug challenge like procainamide to elicit the Brugada pattern? Do I perform an EP study for risk stratification? Do I implant a defibrillator? And it can be very challenging to know what to do in each of these cases, and it depends on your level of suspicion. I was concerned about the cardiac arrest in sleep, which sometimes we see with Brugada syndrome. And so we performed a procainamide challenge. And we considered this wasn't the most positive of procainamide challenges we've ever done, but we considered this to be positive. So the EKG changed, and we thought that this was consistent enough with the Brugada pattern that we gave her a diagnosis of Brugada syndrome. We did genetic testing, and as is often the case, the result was negative. And so I was asked by the patient, what's my risk of having a dangerous event? And I had to go back to some of the data in the literature and advise her that she had a drug-induced pattern, but that she was asymptomatic. And although the family history was pretty frightening to her, that I thought her risk was reasonably low of having a dangerous cardiac event. And so we talked a little bit about that. And in this risk stratification schema that we talked about, she falls here. She had a drug-induced pattern. She's asymptomatic. So in general, she had a low risk. And again, these are the numbers that I showed you before. And so this provided her with some degree of reassurance, even though she was worried about her family history. And so we decided we would just observe, and she was comfortable with that. She came back to see me, and in observation, her EKG pattern looked like this at rest. So this is not during a procainamide challenge. Now she has a spontaneously abnormal EKG pattern, and she moves up in terms of her risk. And this is the stratum of risk that we start to have a hard time with clinically, because we know that there's some risk of events here, but we also don't know that the benefits of implanting a defibrillator and the risks of living life with a defibrillator outweigh the potential risks of in this case. So it's a little bit of a balancing act, and we have to talk to patients about it. So what is your next management step? In general, the community would probably center on observation here. There's some colleagues who might recommend treatment with quinidine, although that's not really the guideline recommended next step. Performing a drug challenge doesn't make any sense because we already have a diagnosis here, and it doesn't give us prognostic information beyond what we already have. Performing an EP study for risk stratification, I talked to you about the controversy in the field. Some of my colleagues might recommend this, and if positive, recommend a defibrillator. Very few people would recommend going directly to a defibrillator at this stage. So this is an unlikely recommendation. E would be unlikely in this particular case. And so this is sort of where we landed. She is asymptomatic and has a spontaneous EKG pattern and a concerning family history, which we're told not to pay attention to in Brugada syndrome. And so in general, folks like this might be observed. Some people would opt for an EP study, and some patients would just specifically say, I want everything worked up, and if it's positive, then so be it. I'll take a defibrillator. Okay, here's another vignette. It's a 35-year-old man who had a ventricular fibrillation cardiac arrest. It occurred after exercise, possibly after he had been in a sauna. He didn't recall the details. He had no family history of arrhythmia or cardiomyopathy. This was his EKG. And again, this is an abnormal EKG pattern. He also has something else that we often see in people who have an SCN5A mutation, where there's a little bit of delay in the electricity getting from the top to the bottom of the heart. We can see that here. And he, sure enough, had a genetic variant in SCN5A that causes the transcription of the gene to be prematurely truncated here. So the translation of the gene. So when the protein's being made, actually, it doesn't successfully complete the formation of the protein. So what is your next management step? Start quinidine, perform an EP study for risk stratification, or go directly to a defibrillator. Well, this patient falls into that highest risk category. And so for this patient, we recommend a defibrillator. And basically, these are the treatment recommendations in a very oversimplified table here. There's a question about, is there a leadless defibrillator? There is not a leadless defibrillator, but what has emerged in the last few years, which might change the calculus, is that there's a subcutaneous defibrillator. So most conventional defibrillators go under the chest here, but they go in the vein and into the heart. So they're in the bloodstream, and there's a lead that you live with for the, for the foreseeable future and potentially indefinitely. Now there's a defibrillator, and there's probably going to be some more innovation in the space that just goes under the skin. Basically, it's bigger. There are some drawbacks of it, but it is completely outside of the blood vessels and outside of the heart. And as a result, there's very little risk of one of the potential complications, and that is infection. And if it were to get infected, there's a much lower risk that the heart would be infected. There seems to be, we think, a lower risk of having to take the lead out, or a lower risk associated with having to take the lead and the hardware out if we needed to for some reason in the future. And so this has potentially opened up a new avenue. And we don't know if that innovation is going to affect how we think about this tricky category of patients that are asymptomatic, that have a spontaneous EKG pattern. There's not a lot of data there yet for us, but that's one of the innovations. So I think this is my last vignette. This is a 42-year-old man with lightheadedness and chest discomfort. He presented to the ED with chest discomfort. He had fainting, we call it syncope, 3 times over a 2-year period. 2 sounded vasovagal. When I say vasovagal, that refers to sort of the common form of fainting. Maybe you saw blood, maybe you were frightened, something like that. The third one was not precipitated by any clear precipitant, but again, it was atypical. And the thought was that maybe it was also vasovagal. We call it neurocardiogenic at some point. Basically, the point here is that we felt like it was less likely to have been caused by an arrhythmia. There's something fishy about the fainting episodes that this particular patient had that made us think that this doesn't seem necessarily like an arrhythmia. The rest of the workup was unremarkable. This was his ECG. Again, a little abnormal, but not a Brugada pattern. We talked to him about things and tried to figure out what he wanted to do. And he said, after a lengthy discussion, to go ahead with a procainamide challenge. And the procainamide challenge, we interpreted this as positive for a Brugada pattern. Again, not the most strikingly classic Brugada pattern, but we considered it positive. We did genetic testing. Sure enough, he had a genetic variant in SCN5A as well that we thought explained the EKG pattern. And then the question becomes, what is your next step in management? Do we observe? Do we perform an EP study for risk stratification, or do we implant a defibrillator? So he really fell into this low risk category. He's asymptomatic, drug-induced pattern. We didn't put him in this category in this row because we didn't think the fainting episodes were due to an arrhythmia. We thought that these were from the more benign form of fainting. And so we didn't put him into that category. But on subsequent occasions, he returned with a spontaneous pattern. And sure enough, he ended up in this category, which happens not infrequently. So his risk went up a little bit. And so again, the question is, do we observe or do an electrophysiology study here for this patient? And again, most patients and most of the community would settle on observation. There definitely is rationale and justification performing an electrophysiology study in these patients as well, though. And that's a shared decision that has to be made between the doctor and the patient. What is the current thinking regarding type 1 versus, sorry, my dog, I think, wants to come in. Come on. Oh. Maybe not. She just wants to watch. What is the current thinking regarding type 1 versus type 2 and type 3? Seems type 1 is diagnostic, but our type 2 and type 3 still recognized as being suspicious of Brugada. Has that thinking changed? Yeah, great question. So these days, you either have a type 1 pattern or you don't, but in certain circumstances, it's well known that the EKG can look a little atypical. That used to be classified as a type 2 or type 3 Brugada pattern. The problem is that those patterns don't necessarily result in a type 1 Brugada pattern when somebody's given procainamide or ajmaline or flecainide. So the nomenclature and the approach has changed a little bit, and those aren't usually referred to as type 2 or type 3 ECG patterns anymore. Having said that, if an individual comes in and they have a suspicious history, maybe they had a fainting episode, maybe it sounds arrhythmogenic, and maybe we look at the EKG and it looks a little atypical and maybe would have been classified as a type 2 or type 3 pattern years ago, we'll take that seriously. And that might be a patient in whom we might be more inclined to say, do a procainamide challenge or flecainide or ajmaline to just sort of solidify and confirm that what we think is really going on is Brugada syndrome, because we can get to a type 1 pattern if we do a test like that. And this might be the kind of patient that we pursue that in. And so I think this is one of my closing slides here, 2 slides after this that are quick, but the unmet needs. And I wanted to just point this out to you. You know, we still just don't understand what we know that Brugada syndrome tends to run in families, but we just don't understand what the genetic causes of the condition are. So there's a lot of work we have to do. And a lot of that will take the participation of patients who are interested in advancing science and want to contribute DNA and some of their medical data to helping us do that. What are the molecular mechanisms of Brugada syndrome? I think that follows from the above. I think if we can figure out what the genetic causes are, then we'll start to identify the pathways. And that might lead to us understanding the molecular mechanisms of the condition. And that also in turn might even lead us to getting to this last bullet, which is developing appropriate therapeutics that are mechanism specific in Brugada syndrome. But we also need a better handle on risk stratification among patients. And I told you about this controversial area and scenario where we see a patient who's got a type 1 pattern spontaneously, but has never had symptoms before. That's a challenge for us. And I think we need better tools for risk stratification, particularly among those patients, and figuring out who should receive an ICD and perhaps even what type of ICD. We talked a little bit about the new innovations in technology. So these are some of the unmet needs. There are others, but these are some of the more prominent ones. And I want to just show you, I'm proud of a project that we're pulling together right now that is part of a family of studies that will be under an umbrella called Link My Heart. And I'm especially proud to partner with the SADS Foundation on this when we get this off the ground, but right now it's under construction. This particular project will be the brugadaproject.org. If you go to this website right now, you'll get nothing. But we're trying to build an online portal and biorepository where patients who are affected with Brugada syndrome can volunteer and sign up, and we can send a saliva kit out to them, and they can send in a sample of DNA if they're interested in participating. And then from there, we'll be able to hopefully start to address some of the unmet needs that I highlighted on the slide prior. And so this is a joint effort. It takes a village to do everything. And here are some of the folks on our team that are participating in this project right now. And there will be more to follow. This is under construction. We're just starting to get this off the ground, and we're hoping that within 2021, we'll be able to, in the next few months, go live with this, and perhaps you'll hear more about it. And I'd also like to acknowledge our local cardiovascular genetics program at the Massachusetts General Hospital. Really proud to work with a bright and engaging group of people who are incredibly thoughtful on our team. And I think I'll close with that. Thank you again for the chance to speak tonight, and I'm happy to take any additional questions.
Thank you so much, Steve. This was wonderful. And I appreciate you kind of following along with the chat and the questions. You stayed up with them. We have one more here, I think, that we haven't gotten to. Justin, for a patient that has Brugada with an ICD in place, how concerned do they need to continue to be in regards to fevers, COVID, et cetera?
Yeah, great question. That's a tough one. I think we just don't know the data, and I think the general precautions, I don't want to cause undue anxiety. So although we know that there's a link between fevers and a Brugada pattern and a risk of arrhythmias in patients with Brugada syndrome, I don't think I'd be doing anybody a service by creating anxiety about COVID beyond the anxiety that already exists in the community about coronavirus. So I'd say just be smart, use good hand hygiene, keep your distance from people, wear a mask, and get vaccinated if you can. And if you do find that you are affected, then take Tylenol and try to minimize your fever and your temperature.
Okay, thank you. Cindy, you have a question?
Yes.
Go ahead.
My oldest son, who is 18, and I both had our genetic testing done, and we both have Brugada. We both show up on our EKGs. He's type 1. He has a pacemaker defibrillator because he also has sinus node dysfunction. He's had 4 heart stops. My youngest did not test positive for the SCN5A gene like we did, but I'm still scared to death for him. He's had syncope episodes. He gets lightheaded all the time. You know, our EPs, you know, they kind of just don't, they kind of push us away with him. You know, they're not really concerned, but after seeing my oldest son have, you know, several cardiac arrests, I just am so worried about him. And as far as I could tell from what all the information that you put out there, I should have him followed more closely, maybe yearly or something like that, to see if it changes. Or is it because my other son and I have the S5 gene that he would be lower risk?
Yeah, great question. So first of all, I'm sorry for what your family has gone through, and I can hear your concern in your voice, and I appreciate it and understand it. I think so the first question about the gene part of it is, how confident is your medical team in the genetic variant that has been found in folks in your family? Because sometimes we can be really confident that a genetic variant is the underlying cause of a condition in a family, and other times we're much less confident when we look at it, and we'll even classify it as a variant of uncertain significance, for example. But what I've seen in the medical records is that sometimes patients or families are not counseled properly, and they get a little confused about it, and they think that they're affected or carrying a genetic variant that poses risk, and maybe they don't. So without looking at it, I can't say, but it's an important distinction, because if it's a really high confidence genetic variant, and people are certain that that is a genetic variant that's related to the condition in the family, then if other folks don't carry that particular variant, then we know that they're off the hook from that particular gene variant. So that's an important distinction. Now,
Okay.
on the clinical side, I think the question about fainting episodes that's important is, again, it gets back to the clinical degree of suspicion, and do the doctors think that any fainting episode is related to an arrhythmia, or do they think it's related to something else? Sometimes we can be really confident, just like the genetic variants, based on the clinical history. Sometimes we're less confident based on the clinical history. And in some cases where it's ambiguous, we talk about monitoring, we talk about implantable monitors under the skin. That way, if we catch an event and somebody has a fainting episode, we can look and we can say, okay, what did they have an arrhythmia during the event? And that can be pretty reassuring. So to me, it sounds like in your family, there's a combination of things. One is, what's the degree of concern about the genetic variant and confidence? If it's really high, and we know that one of your sons is not carrying that genetic variant, that's quite reassuring. And then the other piece is, what's the degree of confidence in the fainting history, and whether that is related to an arrhythmia or not? How ambiguous is that history to the clinical team? Does that make sense?
It does. It does. And I'm just hoping I'm doing everything right, because it can be very overwhelming. We found all this out like 2 years ago, and it was a fluke that we found it out. But my older son and I had both been having symptoms for years prior. So it just.
Have you seen sorry, go ahead.
Oh, it's just more food for thought.
Have you seen it sounds like you've seen electrophysiologists. Have you seen a geneticist or a genetic counselor? Okay.
Yes.
All right. Yeah. So,
Hi, this
I
is
think
Jan
you're
again,
out.
and I just wanted to say to you, I hope someday we get to a point when we take our family members into the emergency room and tell them they have Brugada syndrome because they're having problems, that they don't have to look it up on the computer to even acknowledge what it is.
Isn't that the truth?
Mhm. Okay, we have a question. What's the risk of driving or swimming?
That risk is very low, in particular Brugada syndrome. You know, I tend to be a little bit cautious. There are some conditions where we, for legacy reasons and maybe some real kind of association reasons, we get a little more concerned about swimming in particular. But in general, I tend to be circumspect with patients about swimming as an activity. I don't think people should avoid or have to avoid the water. But if somebody has had a cardiac arrest before, then swimming is probably not the optimal mode of exercise, even if they have a defibrillator, because if something happened in the water, that would be, that could cause some problems, as you can imagine. So I think the risk is small, but I try to be cautious with patients just about swimming in particular. The risk of driving is small too.
Thank you. Justin asks, how often should the children of a symptomatic spontaneous EKG Brugada patient get an EKG to screen them? So how often? And then also, is this a lifelong screening they will need if they continue to test negative, or is there an age at which they should be considered safe?
Yeah, great questions. So I think the first question is sort of how often should somebody who has a first degree relative who's affected be screened? Well, if that first degree relative has a causal genetic variant that's been identified, then that individual, that other first degree relative, could opt to have a carrier test to see if they carry that variant or not. If they don't, and they have a normal EKG, that makes you pretty confident that they're unlikely to develop the Brugada syndrome, particularly from that particular variant. And so they sometimes may be dismissed with proper counseling from routine follow-up. If, on the other hand, like many patients with Brugada syndrome, there's a negative genetic test, they're so-called genotype negative, then it becomes a little more challenging. And usually I'll recommend to a patient that they come back annually, roughly, anywhere between annual and 18 months, to get repeat ECGs and just check in and let me know what's going on. And sort of that's how we approach it. It also gives us an opportunity to talk a little bit about developments in the genetic landscape. So if a family member had undergone genetic testing, maybe there's a variant of uncertain significance identified, we can revisit that variant at that time and say, has that been reclassified? Has that been classified as a pathogenic variant now? And do we need to think about genetic testing differently in you? So that's an opportunity. And then I think in terms of how long you do until what age do you do the screening or repeat follow-ups? This is a hard one with Brugada syndrome because it's an adult onset condition. So there's not really a clear age at which to stop screening. I think I saw a patient in her 80s not long ago with Brugada syndrome. So what we do know is from reasonably good data that the risk of having a dangerous event tends to go down among older individuals with Brugada syndrome. Having said that, there's no real clear data-driven recommendation for stopping the surveillance. I think that has more to do with what the potential decision-making would be on the other side of that. So if you found a positive ECG, what would that mean? What would you do differently in that person? Would they want a defibrillator? Maybe they don't want a defibrillator. And that might drive the discussion about screening.
Thank you. If you are type 1 spontaneous, what should the quote observe consist of, i.e. annual ECGs, echoes, cardiac MRIs?
Yeah, I would typically do an annual EKG. I would definitely, almost everybody who has a type 1 pattern, I'll do some deeper level cardiac imaging. I try to get an echo at a minimum. And if I can, I'll get an MRI as well. And to me, that kind of sets the stage and helps me understand what the cardiac structure and anatomy looks like. Obviously, with that recommendation, there's the avoidance of the sodium channel blocking drugs. There are fever lowering medications. There are other things that we talked about in terms of lifestyle, but that's usually what it'll look like. And then every few years, I don't repeat MRIs that routinely, but every few years I'll get an echo. So it might be every 3 years or so to 5 years, just to make sure that I'm not missing something else that's underlying all of this.
Okay, thank you. Kristen asks, I have been diagnosed with Brugada along with several family members. We have participated in research studies with Dr. Woodrow Benson. How can I learn more information about potentially participating in future research studies?
I think I would say stay tuned, and I would say SADS is probably a great resource for you for figuring out what is going on in the field. And so yeah, I hope there will be more going on in the near future.
Mm-hmm. And Kathy asks, what is an electrophysiology study?
Sure, great question. So an electrophysiology study is a procedure in which we place catheters, so floppy metal or floppy plastic cables into the heart, and on those cables are little electrodes, little metal tips, and those metal tips basically can carry electricity. So we put the catheters in through the groin and the femoral vein, and we feed them up into the heart using X-ray guidance. We put them in the heart, and then we put them in certain spots in the heart. And then we have a little machine that we can turn on that delivers a tiny current of electricity that you don't feel, doesn't shock you. But basically it will cause the heart to be stimulated in that spot. And because the heart is connected electrically, the whole heart contracts when we stimulate that spot. And so the idea in electrophysiology study is that we measure the electrical activity in the heart, we measure the nerves of the heart, we try to figure out how fast or slow they conduct electricity. And then in addition, what we can try to do is figure out whether we can induce some of the dangerous arrhythmias that we are concerned about. That might sound very counterintuitive, I understand, but actually in a controlled setting, that can be informative. And so we do that for certain conditions. And the controversy in Brugada syndrome is whether that adds any information or not, because there are conditions in which we know it helps and conditions in which we know it doesn't help. But the idea is that we can pace the heart, and then we can introduce an extra stimulus that acts like a premature beat, and we try to catch the heart off guard a little bit, if you will. And if we can catch the heart off guard, then it can induce this dangerous arrhythmia that in a controlled environment we can get somebody out of, so it's not so dangerous in that environment. If we can get the heart into that arrhythmia and catch it off guard easily, then that usually tells us that this person has an increased likelihood of getting an arrhythmia spontaneously out there when they're not in that controlled setting. That's at least the thinking behind the use of the test. If it's really hard to catch the heart off guard, then our thinking tends to usually be that we think that it's less likely that that individual's likely to develop a dangerous arrhythmia outside of the hospital. And so we think that they're lower risk. So at least that's the rationale for doing an electrophysiology study, to get some risk stratification information.
Excellent. Well, thank you, Steve. Those are all the questions. Does anyone else have a question they'd like to either share verbally or in the chat? We've had great questions, and I want to thank you, Steve, for completing this webinar and addressing all these questions from our patients. Oh, here's one right here. Amy, is there any evidence that hormonal changes during puberty would increase risk?
Yes, great question. So it may be that the hormonal changes are what drives that male to female imbalance in the ratio of, remember I said something about 8-to-1 men to women are affected more commonly. So, I mean, certainly women are affected. There's some speculation that hormonal changes are what's responsible for both that male predominance of the Brugada syndrome, as well as that age of onset being a little later. But you've heard today that women can be affected. You've also heard today that children can be affected. So that's not the whole story, but that may be part of it.
Okay, thank you. Scott added one. If we'd like to continue to learn more, do you have a recommendation for resources to do so? Besides stopsads.org as our website. Anything else,
Yeah.
Steve?
Yeah. No, not the brugadadrugs.org would be another site to look at, but stopsads.org I think would be a good site to look at too.
Excellent. Well, I'd like to thank everyone for participating tonight and remind you we'll send a link to the recording to you from our YouTube channel in the next day or so. And so I appreciate you being a part of this. And if you have other questions, we have our general email, sads@sads.org, that you can also send any questions to. So I appreciate all your time tonight. Thank you so much.